Hi, this is Kevin Tran, and I will be responding to case connection number 4, and I will be answering questions 1 and 2. So, question 1. The best diagnostic test to distinguish between a urea cycle disorder versus a beta oxidation disorder is plasma glutamine testing. Glutamine acts as one of the non-toxic carriers of nitrogen, and in regular functioning, it is released from the tissues where it enters the bloodstream, where ultimately it enters the liver, where via glutaminase, glutamine releases ammonia and reverts back to glutamate. This ammonia then enters the urea cycle, where eventually it gets excreted into the urine. In patients with suspected urea cycle disorders, not only are ammonia blood levels increased, but also plasma or levels of plasma glutamine. This makes sense due to the fact that if the liver is unable to process ammonia, there should, in turn, be upstream increased levels of glutamine. Thus, elevated levels of plasma glutamine should indicate increased levels of ammonia, which points towards urea cycle dysfunction. Blood glucose testing would fail to distinguish and identify a urea cycle disorder, as blood glucose levels will present within normal ranges in the setting of urea cycle dysfunction, though it could help in identifying beta oxidation dysfunction. Urinary acid testing is generally used for measuring levels of uric acid in the urine and is used in the diagnosis of kidney stones and gout, and so it wouldn't really necessarily be that useful in urea cycle dysfunction diagnosing. Serum fatty acid testing would be useful in monitoring type 2 diabetes, as increased beta oxidation is generally found in patients with type 2 diabetes, though it would not be useful in diagnosing urea cycle dysfunction. Additionally, serum free fatty acid testing would not help in the detection of increased ammonia consistent with urea cycle dysfunction. Patients with increased levels of orotic acid are likely suffering from ornithine carbamyl transferase deficiency. Ornithine carbamyl transferase is the enzyme that catalyzes the reaction between carbamyl phosphate and ornithine to form citrulline. Dysfunction of ornithine carbamyl transferase would increase levels of carbamyl phosphate within the mitochondria. Excess amounts of carbamyl phosphate can then spill into the cytosol, where it participates in pyrimidine synthesis, which ultimately results in increased levels of orotic acid in the urine. One enzyme that is least likely to be impaired is carbamyl phosphate synthetase, as the presence of increased levels of orotic acid necessitates increased levels of carbamyl phosphate, which is synthesized by the aforementioned enzyme carbamyl phosphate synthetase. That concludes my answer to question 1. Moving on to question 2. So, patients with phenylketonuria are unable to readily metabolize phenylalanine, and as a result, they require specific diets that minimize their phenylalanine intake. The disease is characterized by the absence of the enzyme that metabolizes the conversion of phenylalanine to tyrosine, which is phenylalanine hydroxylase. As a result, exogenous tyrosine supplementation is necessary, as tyrosine will become an essential amino acid in the place of phenylalanine. Potential causes for the presentation of phenylketonuria is generally genetic in nature and is a result of dysfunction of the phenylalanine hydroxylase encoding gene, which presents itself as a compound heterozygote. Phenylketonuria is an autosomal recessive genetic disorder, meaning that the presentation of phenylketonuria is contingent on the presence of 2 defective phenylalanine hydroxylase encoding gene alleles. While there's clear etiology for the presence of the disease via the defective genes, clinical phenotypic variation between siblings with identical genotypes suggests other genetic and possibly environmental factors that contribute to the clinical presentation of certain cases. Researchers believe that modifier genes are also responsible in the clinical presentation of phenylketonuria, though to date they have failed to identify any modifier genes. The evidence that supports the presence of modifier genes comes in the form of differences in how phenylalanine is transported to the brain, which generally results and presents in variation in how it clinically presents in regards to the symptoms and the severity of the symptoms. Environmentally, some factors that contribute to the clinical presentation of phenylketonuria include, but are not limited to, the age of diagnosis, the age at which metabolic control therapy is implemented, and the degree of metabolic control. In regards to BH4 loading tests, it can be inferred from the graph that patient B likely does not have fetal phenylketonuria, while patient A's results likely confirms the diagnosis for phenylketonuria. As we learned, BH4 is an essential coenzyme in the conversion of, cofactor in the conversion of phenylalanine to tyrosine via phenylalanine hydroxylase. The fact that patient A's levels of phenylalanine fail to drop and is steadily increasing post BH4 administration implies that they have phenylalanine hydroxylase deficiency. Patient B's phenylalanine levels drop following BH4 administration, meaning that they are able to readily metabolize phenylalanine to tyrosine via phenylalanine hydroxylase, which implies that they, in fact, probably do not have phenylketonuria. And that concludes my oral presentation for case connection number 4.